Work history of 25 years at Harvard and now at Washington University. And the Growing Up Today study, both of which are prospective cohort studies following thousands of people into the future. He is currently a member of the Institute of Medicine and is the PI for a Cancer Network program grant to eliminate health disparities. So today I'm looking forward to hearing about Graham Kolditz's view of implementing cancer prevention to eliminate cancer disparities. Welcome, Graham.
Thank you. Well, thank you. It's a pleasure to be here, and after being invited by Elizabeth, she also picked the title of my talk and then left without bothering to hear what I have to say. So I hope I do justice to the topic that she pushed me to speak on here today. So I will try to stand still and not walk around, which for an hour will be a challenge, but if I succeed, I will give you a sense of what we are challenged with and how we're responding to issues of cancer disparities in our prevention and control program. I will place this in some context and talk a little about broader issues of the application of implementation science to improve population health. To give you some context, I want to remind you St. Louis is on the other side of the Mississippi River, sitting on the junction of the Missouri, the longest river in North America, and the Mississippi. To this day, I don't know why, when the longest river joined a shorter river, the name of the shorter river persisted, but that is the story, draining about 34 of our states. St. Louis has got a very mixed history, including French names in its original establishment, and obviously Louisiana Purchase and other parts of American history that I never learned when I was growing up. I also didn't learn about the Cahokia establishment just across the river, still on the east side of the country. Large American Indian city, basically, that in around the year 1200 was actually larger than any European cities. Culture center for North America from 600 to 1400. Now all that's left are the mounds that I just showed, but certainly not inconsistent with trading paths and many of the other features that persisted when European American settlement crossed the Mississippi, and St. Louis was a major gateway to the West. By 1904, a tug of war was held, actually at the first Olympic Games held outside of Europe. The 1904 Olympics held at Washington University on their athletic field, and in 1904, tug of war was an Olympic sport. We now have gained weight and it's no longer fashionable to do tug of war. To give you a little political economy perspective on Missouri, we have some blue edges, Kansas City, St. Louis City, and we're red in the middle, not unlike the country as a whole. And in that context, we're sitting on the east side of the state in a comprehensive cancer center with a prevention and control program that is really challenged to identify strategies to move beyond describing disparities and actually, as we say in our goals, take discoveries through to delivery at the clinical and population level. And so our leadership challenge and our ongoing faculty recruitment effort is very much around how we can build out the skills, strategies, and approaches to eliminate disparities. So we've got funding from NCI, that's the centerpiece of this activity. In fact, before we had NCI funding, we actually had Cancer Center funding to really begin the program for the elimination of cancer disparities. The funding acts as a core that supports community engagement as well as a major research project that I'll talk about in a little. In an overarching sense, breast, prostate, colon, and lung cancers account for more than half of all cancer in the US and have disparities in our region that I will describe in a second. Early on, the system invested in a mobile mammography van to deal with some of the access issues, and we can talk about that. And we have many other activities in the community that are part of the trust building and identification of priorities for research and programs. And it's worth emphasizing that while we have core funding from NCI, we have additional funds from Komen, from the American Cancer Society, and other local foundations to build on this work and move forward with the prevention and elimination of disparities. A little context on the actual rates of mortality from cancer in our state to really let you see what we're facing. We can start on the national website. You probably can see this morning I updated my slide at 5:25 a.m. and these are the latest available data showing the difference between Missouri in blue and the national cancer mortality. And you can see that, well, maybe Missouri's lagging behind the United States as a whole with more than 50 cases per 100,000 or 50 deaths per 100,000 gap. Probably not something to be thrilled by when we're actually sitting in a major medical center, major medical school, and a NCI designated comprehensive cancer center. We can move from just looking at that to breaking out the white, all Missouri breakout whites, and they maybe look a bit better, a bit closer to the national data. So you can guess what the next slide will show. This is our mortality excess among African Americans. The same overall pattern as the US, but horribly behind in terms of the burden. Lung cancer, we can look at the same US white mortality in red, black mortality in blue, and we can again break out the white mortality in green and the African American Missouri data in orangey brown. So what else is fascinating here? Nancy Muller and Al Morrison taught me back in cancer epidemiology, you really got to understand the rates that you get from your registries. And you look at this and you go, even in the whites, we are very flat for lung cancer mortality compared to the US overall reduction here from the 1990s on. And if you dig into that, you'll actually learn that Missouri's now got the lowest tobacco tax of any state in the nation. And so we're just showing at some level what strong political opposition to taxation, because it might interfere with God's will, in the red part of our state, actually gives us a major excess of lung cancer mortality above what could be achieved. And obviously the African American pattern really reflecting national, showing the downtrend from the 1990s on. So if you go to the ALA website and check your state report card, you can be proud that your state is sort of bottom of the rank with Fs for all 4 areas that they grade our states on. Prevention and control, our state doesn't believe in spending money in public health. We'll focus on tobacco right now, so that's low. Smoke-free air regulation isn't a good thing. That's interfering with business, so we fail there. We've got community-based activity. St. Louis has gone smoke-free for bars in the last 2 years, but it's town by town. Tax, we're now the lowest, and youth access, they're actually still, despite regulation, it's still possible to buy single cigarettes in the city of St. Louis. There's no enforcement. And brilliant experiment, we have the Mississippi. On the other side is Illinois with one of the more progressive tobacco taxes policies. And we have a very nice contrast of lung cancer between Illinois and Missouri. So that's a little more on the context in which we're working. So let's look at county level data. Drill down, still available on the national website, data extraction tool, and you see that the goal for 2020 is to get to 160 deaths per 100,000. Missouri's at 190, well above the national average. And yet the goal, we actually have out of our counties quite a few that are meeting the national goal. We have more and maybe even more up at horribly high mortality. And I'll talk to you as we go here about the southeast corner. This is the Mississippi running down here, the Missouri running through the state. Southeast corner and the boot heel of the state sticking down into Arkansas. You can also look at a measure of poverty. Here, I pulled off just the persons below poverty. National average is around 13% of the population living in poverty. St. Louis City, we're up in the 25%. These counties that I showed on the mortality map for the highest cancer mortality in the state also have the highest poverty, up at around 25%. You could almost overlay the cancer mortality and the poverty and not know I'd changed the maps. So we have a question, what can we do system-wide to think about access here as one of the issues I will come back to. It's about a 4-hour drive from St. Louis down to these more rural and remote counties. Put this in context, David Satcher has a number of pieces, but I like this data. And the next slide here, looking at the gap we have between African Americans, excess deaths, investing in technology. Why don't we invest in just getting the African American rates to be the same as the whites, and we'd avert over 800,000 deaths in a decade. If you take a longer term view from 1960 to 2000, the standardized mortality rate, excess of 40%, has actually worsened for men in the 40-year period after 1960, and that gives about 80,000 excess deaths each year. That's persisting. So to turn to breast cancer as the first place that our program for the elimination of cancer disparities took on, I just want to remind you that, like the totals I showed, we have substantial black-white difference with excess black breast cancer mortality, and whites seem to be doing nearly as well as the national averages. So the first step in mobilizing around this issue was actually undertaken by Mario Schutman and colleagues, who looked at the state mortality from breast cancer and identified this area north of the city. This is the city of St. Louis, which actually broke off from the outer counties around 1890 to 1900 to keep the poorer people out of the city, because this had 800,000 people, was one of the largest cities in the country. Probably you could replace St. Louis with Baltimore and you'd have the same story. All the wealth is now out here, and we've had the city population decreased by a third. We're left with the 25% of the city population living in poverty, but also going into North County, African American population, and the excess of breast cancer mortality shone through clearly there, and actually was one of the first priorities to motivate the Cancer Center to address questions of the causes and strategies to overcome the excess mortality. And we can think of this along the continuum. Screening and access to care is clearly a key part. This is just actually fairly recent state data, combining data over 3 years to look at county level screening, and it still says there's a lot of variation in a state where the breast and cervical screening commitment from the state government runs out 6 to 9 months into the budget year each year, and we have a gap which Komen and others step in to fill. But I want to think that screening is a lot more, and dealing with this challenge is a lot more than just getting access to screening. And we'll look at where the mobile van goes. But Jane Zapka's done a nice job here outlining the fact that after screen detection for any cancer, we're talking about breast right now, but there's many steps along the process towards diagnosis, and then access to treatment, and obviously further follow-up, issues at the organizational level, at the provider level, and the individual level. And our efforts are really focused on addressing access and all for breast and colon across all these levels. At the extreme of follow-up from positive tests to treatment, if you went to the Missouri Health and Human Services website, you'd learn that if you were diagnosed with breast cancer, you could qualify for Medicaid. If you were diagnosed by a provider who's on the list approved by the Medicaid program. Takes you several hours to get to that level of understanding, but it doesn't actually tell you who the providers are. So most women I know don't look at that list before they go and have their mammogram and get into this type of follow-up. So we have a foundation in the Cancer Center that is left over from an earlier incarnation of cancer treatment in St. Louis, and it allocates around $500,000 a year to cover treatment for uninsured women or uninsured patients, because it's actually doing more than breast. You go to the terms of reference of a foundation and then they say treatment for cancer. What happens if a woman in the breast health center doesn't have insurance and has to come back for a diagnostic test? Is that treatment for cancer? Can we tweak the foundation budget to actually cover even the screening test for uninsured women? We've worked through some systems to actually make that possible, but it actually sends a message to the community that there are resources. If you get diagnosed, the Cancer Center can provide state-of-the-art care, even for the uninsured, and that foundation existence is a key part of making some of this engagement of the community possible, and again, building trust with the community. So Jane's figures in the middle, but we've got to work out how you get to have the test, to get into the diagnosis and treatment, and then what outcomes do we really want to measure here to show that a program is actually ultimately reducing the disparities that I started by showing you. So PCAD and our effort fits into this largely at the front end, and some of the administrative piece I mentioned on the funding is sort of in the middle. I'll pose some questions for you on the right-hand side on just what outcomes can we ultimately be measuring here in terms of population health. So we focus on the 4 cancers that I mentioned: breast, prostate, colon, and lung. And we do this with a substantial amount of community input. They have worked with us around the problem definition, understanding the perceptions in the community of cancer and access to care. I showed you some of the epidemiology earlier, just the basic excess mortality, which obviously has with it screening rates and stage at diagnosis, a number of issues in the community around the behaviors that may be predisposing or to access or not accessing care, choosing treatment, choosing to show up for follow-up, a lot of social and behavioral issues. The clinical trials end of thing, again, one extreme on the treatment side. On the community side, we are working to understand the perceptions again around participation in research and building trust that coming to a cancer center will provide state-of-the-art care, and there are options for participation in research. And then the broad end product is ultimately to improve population health measures. If we drill down on breast cancer, on the left we find the problem. I show you the picture. We get some Komen funding. How long does it take for a woman to get from a federally qualified health center provider to actually getting a diagnosis of breast cancer? Well, actually, with community input, design a record review, review the data with the community. The median comes out around 93 days, which probably isn't too bad, but there's at least someone over a year in this distribution, which is not good, to say the least. And that actually led the federally qualified health centers, the cancer center, the referral system, to really go back and look at the flow of patients from primary care to screening, diagnostic, and actual visit with a surgeon. And we've been able to implement that. And the second project listed here actually wanted to see if, after doing some implementation of the system and guidelines, things improved. Well, Komen said, we've already funded you to look at this problem. We don't want to give you more money to know that it's improved. So we found an alternative foundation, but it sort of, one of the classic questions came up, is this research? We're really just trying to evaluate that putting a system in place decreases delay and gets women into care. The community doesn't actually want to call it research because they don't want to participate in research as guinea pigs. They are really interested in improving the quality of care. NCI wants us to be doing research, not other things. So we've gone back and forth with community leaders on when we can call things research, when we are evaluating programs to improve access to care, when it is research and when it is implementation and improvement of health that we're studying with some of the data that are accrued along the way. So the next step down here, dealing with issues in the community, Sarah Gellert's had some more resources to look at perceptions of women diagnosed with stage 4, understanding why they chose either not to follow standard treatment, all sorts of one-on-one data that she's been able to get from them. And in parallel with some of these things, we actually, over a little bit longer time frame here, put together initial meetings of navigators. Within the Cancer Center, radiation oncology has breast navigators, medical oncology has breast navigators, and the breast health service that provides around 25,000 screening mammograms a year also has breast navigators. And they never talk to each other. So we started off, we can buy lunch, we'll find out what's happening, what's working. Then we decided it made sense to talk to navigators out in the community, and lo and behold, we actually had the navigators meet as part of our community input to breast program, and they wanted to keep meeting after they'd worked through implementing these new guidelines and the flow to speed up literally clinician referral in the community to screening and diagnosis. So from that, we actually now have a quarterly meeting navigators from up to an hour's drive away come not to the cancer center. The meeting is held in one of the local libraries, which has way easier access for parking. It's chaired by one of the primary care providers from our integrated health network, the federally qualified health centers. We do the staffing support minutes. The navigator group pick their own topics, and our breast and cervical screening program at the state level is now asking if we can do this in the city region of St. Louis. What can we do in rural areas? You're not going to get 30 navigators all an hour apart. How do you make some of this work? We had pushback from clinicians. You're going to help women go to competition hospitals? Siteman does about 70 to 75% of breast surgery in the city. It's like, no, we're aiming to make sure no women who want access to breast care fall out of the system. We're not driving where they go. Oh, we've got to be careful, we'll be helping the competition. We just sort of ignored that and went forward, and this is now really a self-sustaining effort where navigators share their experiences, literally avoid each of them relearning what works for one, and they are fairly autonomous, but do come back to our breast cancer advisory group with additional issues they want us to be addressing and helping them with. So I think we've got a good dialogue that works at this flow of patients accessing care. And then the final question is sort of what are the surveillance data that we can get to know that the system is working. Very easy to get our own hospital stage data, but if we're only serving 70% of the catchment, we've got to wait for the state tumor registry, which is always behind, threatened by lack of funds, as all tumor registries seem to be, and so we get a delay built in, and literally while we're working with breast cancer as a regional issue, actually getting the active surveillance in a timely manner, I think is still an area we haven't fully solved. So I said we use a mobile mammography van in part to deal with access. This actually has the same digital machines. The mammograms are read in the medical center by the same mammographers who view mammograms. If women come into the center, the van goes to churches, shopping centers, actually goes all the way down here to the boot heel. But what do women do if they get a positive mammogram? What's the system to get from a positive mammogram down here to a local follow-up or a 4-hour drive? If you're living in poverty, the money for a 4-hour drive to St. Louis is not necessarily the first way you want to be spending your cash. So number of issues that this raises. We're in the process right now of analyzing the mammography van data to see that the rate of follow-up for positive mammograms isn't different from the women who are in the health system through showing up at a mammography service rather than the mobile. But it does highlight some of the potential, but also some of the gaps that we may be sort of creating and exacerbating by trying to meet the need for access to mammography. Another success out of the breast community collaboration was the actual supplement we got with ARA funds. NCI sent out an announcement that there were up to $100,000 a year for 2 years supplement to the U award if we had a evidence-based service that we could be implementing, and community advisor basically said, we've got a clinic, we've got a new machine in our close-in clinic. Our North County clinic has the old machine. It's got no staff to use it. We know from Show Me Healthy Women, the breast and cervical screening program, that there's probably up to 1,000 women who are not up to date for mammograms up in North County. Why don't we go for it? So we wrote the application, 95% of the money going to the health center. They had no system to track anyone, and we worked to set up a data system so we could actually track who got screened as a consequence of getting a navigator and mammography technician at the clinic. And we moved through in 2 years to navigate some 750 women, and the money obviously went to a couple of jobs in North County. So it took 2 years to get there. The navigator is retained on staff, so the health center actually built this into their budget. One of our early fears was they'd want us to find the money when the ARA funds ran out, and we were working hard at that, but the health center saw these data and found a way to build this into their budget. And the navigator is now well accepted in the community and is part of this overall network. So our sense is that, again, we're able to have the community decide where we should be focused in our application to ARA funds. We brought in the funds and women got screened. For colon cancer, we also have a community advisory group that meets quarterly. And early on, Veta Sanders Thompson actually did needs assessment and got some NCI funding to follow up on that, all around the perceptions of screening in the African American community specific to colon cancer. Amy James in our group recruited over from Kansas, brought with her an ACS mentored award that was focused on access and colorectal screening in underserved low-income populations. So she reinvented the project in St. Louis, having sort of done a year of groundwork to build relations in Kansas City. And that project has generated some more insights into issues around accessing screening services. Out of the community advisory group, the idea of capturing community understanding of colon screening and colon cancer led to an R21 application that uses photo voice to capture people's stories, with the community doing the actual recording and coming to the Cancer Center to present their results. And they will also be presented through poster boards in our public libraries. In the renewal of our CNP, NCI, in their wisdom, I think, to get through the process of getting funds out of NCI, they said, you've got to have a research project. And we cringed. Trying to call a study in our community a research project, as I've said, is not the best thing. And then NCI's like, well, it's got to be a randomized trial. So we puzzled away. I'd done some intervention work back in Massachusetts, Connecticut, and New Hampshire with Alan Dietrich that was sort of putting systems in place in primary care to increase screening in the primary care setting. But we're in federally qualified health center world, and so we met with the health centers. The community advisory group included a couple of primary care docs from health centers, and they said, yeah, we want to go for this. We'll make our systems change to make it easier for everyone to refer patients for colorectal screening. So we've got a delayed start randomization of health centers in the field, in the city of St. Louis, in the boot heel, and hopefully before we're done over in southern Illinois, really working to implement systems that already are shown to increase screening, but doing this in the resource scarce FQHC setting and with both system level data coming out of EMRs as well as participant data collected before and after the process is rolled out health center by health center. And then in the add-on to all this, the American Cancer Society, in their wisdom, took some money from Walmart and is giving out $50,000 awards. There may be more than one person here who's got one of these to promote colorectal screening, and so they gave 2 of these to us. Amy's leading the effort to really reach out to primary care providers and outside the trial setting, engage them around referring for screening and getting up to date on that. So very different issues between the two, but also some more common themes around access, follow-up, and actual completion of treatment. Another one of our community engagement activities really comes out of our library at the medical center, who, as part of their mandate from the National Library of Medicine, are actually meant to be doing more than talking to academic library users. So they came to us and said, what could we do with you? You're out in the community. St. Louis has got a very old, well-endowed public library system, and so we helped put the 2 of them together, and at this stage they have adapted material for low literacy, low income use. They're stocking this in kiosks at the branches of the city public libraries, and they want to take that citywide as a flow out from just having our program funded and in the field. Other engagement work we do ranges as to the avenue that we're using. Our themes are pretty constant. The St. Louis American, African-American owned and focused newspaper, reaching 70,000 residents a week, came to us about 3.5 years ago saying, only time we ever talk to people at WashU is when they come to us saying, can we run an ad to recruit people for a study? Wouldn't you like to work with us around cancer prevention? How can you say no? So we've developed content. We've tried to counter the rather off-putting ads that the health department run for the breast and cervical program that sort of advertise, get screened while funds last, sort of reminding you that they're going to run out soon. And so we've done range of issues around screening, access, and also our 8 ways to prevent cancer effort that has also gone on to our local TV as a feature of their health activity. We've also worked with the buses. Probably no big surprise. There are different bus routes that run into the low-income neighborhoods than run into the other neighborhoods, and so we could target our advertising, cancer survivor here, has her story in the paper and also her picture and advertising on buses, and we do interviews on a Sunday health segment as a regular feature. So trying to make sure that in addition to working at the provider level, we are getting out at the community level around awareness and resources that they can be accessing. And the other piece here to put this in context, Melody Goodman in our group recently did a quick review of disparities papers published from 2007 to 2012, classifying them by the stages of disparities research, and surprise, surprise, the majority are down at the first stage of describing disparities, and almost all the rest are trying to get at why disparities might exist. And very little in the period she looked at actually addressed interventions and whether they worked or whether they actually were now in communities to actually eliminate or reduce disparities. And so we would like to think that what our CNP is doing is actually working up here with the interventions in access and system level changes on colon and breast screening, but obviously we have other activity that's out there to sort of underpin issues of building trust and making the flow of ideas and ultimately results a two-way exchange with the community. But we've got more than breast and cervical cancer to do. The southeast corner of the state is highlighted, but obviously there's more of the state that's below average as well. We keep pushing ourselves to say we should be able to take lessons from St. Louis and do something to solve the problem, in part in the Southeast. And Rebecca Lobb in our group just got an ACS Mentored Award around implementation at the system level to address access to cancer care in the southeast of the state. Obviously, we'd also like to move to southern Illinois because it's got literally the same problems of poverty and access, just on the other side of the Mississippi River. So there are some challenges that sort of underpin all these different pieces that we have going. When do we have enough data to go forward with these interventions and system level activity? There's actually no data out there that shows mobile mammography vans change outcomes for breast cancer, or if they're there, they're very limited evaluation. So part of our looking at this is identifying gaps that we can, heaven forbid, take data we've been collecting and use it to ask some fairly fundamental questions. Obviously, we're never going to have the perfect answer before we go forward. I showed you how extreme the disparity is, and that may push us to move more quickly, mobilize our cancer center leadership to take this seriously and generate funds. Most of it is requiring multiple disciplines, and we obviously are using a range of modalities from qualitative data all the way through to outcomes. And that, to me, is the essence of a lot of the challenge we have moving to implementation, that we're not able to say, well, we'll implement a screening program and we'll see mortality, say, from colon cancer decrease in 20 years' time. That's a time frame that is sort of not acceptable to funders or to communities. So where do we fill in the changes in the processes that will assure us that we will see improvement going forward? And which of the outcomes can we trust? On the etiology side, we asked, do biomarkers really tell us what's happening with cancer? And here I think we've got many of the same problems. Which intermediate measures of process change really translate to solving these disparities? So the IOM and others have been looking at, oh my goodness, it's complex. We've got sort of cultural context and political context on the left-hand end, and we want some outcomes down the right-hand end of fewer deaths, and lots of pieces in between. Which of those can we be measuring as necessary steps to change on the pathway to the far right of improved outcomes? And in the context of breast cancer, I can tell you that just getting women to diagnosis doesn't guarantee they're going to choose to follow state.
All right, everybody. We're going to go ahead and get started. I'm delighted to introduce Dr. Andrea Galen, who will be presenting this morning's seminar. Dr. Galen is a professor in the Health, Behavior, and Society Department and the director of the Center for Injury Research and Policy. Dr. Galen's research interests are in the development and evaluation of community and clinic-based programs that address health behavior problems affecting women and children, primarily among low-income families in urban areas. So without further delay, Dr. Galen.
Thank you.
You're welcome.
Well, thank you. It's nice to be with you all this morning. So on your visitor day, so are you all pondering whether to come? How many have made a decision? A good decision, right? So the rest of you, we need to buy you a coffee after this. Is that the way it works? Okay, well, good. I'm glad to see you all here, maybe with some interest in behavior change. What I'm going to do in the time that we have together is walk you through, kind of help answer this question whether behavior change is really too tough to tackle, and give you a flavor for how we approach the whole issue of health behavior, understanding health behaviors and helping people change health behaviors. So that's my plan. But although I have slides, quite a few, feel free to interject if you have questions or comments along the way. How many of you have taken a health behavior course in your either undergraduate or master's program? A few? Okay, well, feel free to chime in as we go through this, and hopefully there'll be a little bit of new information for you as well, as a lot of new information for those of you who haven't taken a health behavior course before. So despite that lovely introduction, thank you very much, this is really more about my background. When I grow up, I'd like to study about people. People interest me. I'd like to go to some big university and study all about people. I see you want to learn about people so that with your knowledge, you'll be well equipped to help them. No, I'm just nosy. So if you have an interest in trying to understand why people do some of the things that they do, then this area of work in the School of Public Health, I think will be of great interest to you. So I'm going to cover why do we care about behavior in public health? Are there examples of successfully changing behavior in public health? And then how can we help ourselves and help others to adopt and maintain healthy behaviors? So the first part, why do we care about behavior? I'm trying to fit 30 minutes of daily exercise into my busy schedule. Today I took 120 15-second walks. So there are lots of media messages out there about trying to tell people what they should be doing, and it's often not easy for them to do, or they don't understand our messages. Is it really that important to think about health behaviors such as exercise? Well, I think it really is very very important. And we have to start with understanding what the major causes of death and disability are before we think about how behavior contributes to those causes of death. So this is from the World Health Organization, which shows you the distribution of deaths by leading cause groups for men and women around the world. The males are in the dark blue, females are in the light blue. And you see at the top there cardiovascular diseases, infectious and parasitic diseases, and cancers as the three leading causes. And these are percents of total deaths. So you can see that almost a third of deaths to women around the world are due to cardiovascular diseases, and another 27% of deaths in men are due to cardiovascular diseases, and so forth. So we see these indicators of health status for the world, and in the next slide I can show you some of the indicators for the United States. And don't worry that you can't read the words, because the picture, the color here is what I want to call your attention to. This is the United States, rank ordered leading causes of death 1 through 10 down the left side, and the age groups across the top from under 1 to over 65. And the last column is the total deaths. So the blue boxes, anybody want to hazard a guess? This is a leading cause of death from ages 1 to 44. The blue boxes are? Unintentional injuries. Good, someone can read it. Very good, very good. Yes, the blue boxes are unintentional injuries, the red boxes are homicide, and the green boxes are suicide. And so this tells a very important story about the United States in terms of the role that injuries play in causing death. And I'm going to talk a little more about that as we go through the rest of the talk. But I wanted to show this to you because the total column over here, the number one ranked cause of death in the U.S. is heart disease, followed by cancer, followed by cerebrovascular disease. Chronic low respiratory disease is 4, and unintentional injuries is the 5th leading cause of death overall in the United States. And those boxes are colored in because I'm from the injury center and I'm not allowed to leave home without this, because many people don't realize that injuries take such a huge toll. But stepping back, we are still also obviously very concerned about heart disease, cancer, and the other leading causes of death. Now, from a behavioral science or behavior change perspective, why would we care about those? Well, because if you break down those conditions, cardiovascular disease, some of the most important causes of those health conditions are smoking, physical inactivity, unhealthy diet. You see unhealthy diet and smoking as significant risk factors for cancer, stroke. You see other behaviors appearing in terms of unintentional injury, alcohol use, unsafe driving, seat belts, etc. Infectious diseases, a huge problem globally. Failure to receive immunizations, inadequate diet. Suicide and homicide, you see alcohol use, handguns. So you can see that it's one thing to talk about the health problem, but when you peel it away, what you find is that behavior is a huge underlying factor in causing those health indicators. And it's not just me saying that. Actually, they've looked at it very rigorously, and there's an enormous body of literature on these kinds of risk factors, behavioral risk factors. But here's an example of trying to quantify how much behavior contributes to these causes of death. And this was work done in 1990 and then replicated in 2000, where they looked at the epidemiological literature on the amount of risk or the amount of risk of death that could be explained by different underlying causes. And they called these actual causes of death in the United States. And what this shows is tobacco use was responsible for 400,000 deaths in 1990, or 19% of all the mortality. And in in 2000, it was 18%, or 435,000 deaths. And so you can see for each of the major kinds of behaviors that you all realize are important, you can see how much they contribute to these actual causes, to the causes of death. Poor diet, physical activity, 14%, 17%, and it hasn't really changed that much. If you look at the bottom line, the total contribution of these behavioral factors is 50% in 1990 and 48% in 2000. So you can quantify the extent to which behavior is a contributor, and it's a large percentage, as these data show. Oh, good question. So that would be the infectious agents that cause the death, right? But if you think of yeah, okay. Well, if you think about that's a good example, hand washing that allows microbial agents, or the lack of hand washing that allows them to take hold, right? And some of the behaviors around HIV, those kinds of things. So what do we do about it as a country? Well, sadly, from my perspective, we're not doing enough. Less than 5% of the $1 trillion spent annually on health care in the U.S. is devoted to preventing lifestyle-related risk factors. So while we recognize that it's important, when we look at the funding for the kinds of intervention work that we need to be doing, we see that a whole lot less is going into prevention than into treatment. So that's kind of here's the problem. Here's why behavior is important. So can we really do anything about it, given that there's little investment, or there has been historically little investment? What can we do about it? So are there examples of successfully changing behavior? This gum doesn't help you stop smoking. It helps you accept the fact that you have bad habits and you'll never be perfect. So what the heck? Just give them the information and hope for the best, right? Well, I really, and there's a lot of that kind of cynicism around, I think, sometimes. And I think that we need to step back and look at a couple of examples and see where we've had real public health successes and what role has behavior change played in those real documented successes. So I want to go through just two examples. This is one very well documented public health success story, and I'll ask you if you might guess what it is. You see the blue line here over time, 1925 to 1995. The blue line is going down, something's going down, while at the same time, the green line, something else is going up. So you know the success part is that the blue line's going down, right? Okay, I'll give you that. Automobiles? Yes. Say automobile. Seatbelts. Yeah, so automobile usage and seatbelt saving death. Good. Very close. Very close. Excellent. Yes. I usually have to give the hint that I'm from the injury center, but you got it right away. So what this is motor vehicle-related deaths per million vehicle miles traveled is dramatically going down over that period of time, while vehicle miles traveled is dramatically going up. So you can't get a better picture of success from a public health perspective than one where exposure is going up, but deaths are going down. So what have we done right? What have we done that contributes to this? And one thing has already been mentioned, seat belts. What else? Airbags, car seats, car designs, speed limits. I couldn't see. Any good? These are all great ideas. Others? Road design. Roadways. Good. Anything else? I'm sorry? Legislation regarding driving while intoxicated. Drunk driving. I think you got them all. Excellent. Okay, great. So people who have studied this sort of systematically have consistently identified that there are a handful of things that we can attribute this success story to. Oh, and by the way, the CDC put out, the Centers for Disease Control and Prevention published something a couple of years ago about what were the 10 greatest public health achievements of the last century, and motor vehicle safety was one of them. And these were the data that they used to make that statement, the graphs that I showed you. So what most people who have studied this say in terms of behavior is at the bottom here: seatbelt use, car seat use, and drinking and driving. And in seatbelts you could include car seats, I suspect. Oh, they're separated out, yeah. I was thinking of airbags. So airbags would actually be under motor vehicle safety standards. So the idea here is that there are things that we do to change the environments, like interstate highways. They've added tremendous safety to our roadways. Better roadway designs where you can actually have room to escape if you're in a dangerous situation without going over a cliff or into a tree, for example. And then all the motor vehicle safety standards, which have airbags is one of those, but shatter-resistant windshields, the steering wheels that don't impale you, etc. There's many, many, many of them. But without changing the behavior alongside of that, you probably wouldn't get as much bang for your buck. So seatbelt use, car seat use, and drinking and driving. And you're right that a lot of these behavioral changes were possible only through a combination of education and policy change. So when we say, oh yes, we can change behavior, the next question is, well, how do you do that? And so in these examples, all of those have a strong policy, community activation, and education component to actually get those things on the books and enforced. Okay, so here's another one that it was a major public health achievement, and you can see something that was increasing and then over time decreasing, 1900 to 1990. Brilliant. Great. Yes. Okay. Yes. Smoking. Boy, first time. That's great. It was adult per capita cigarette consumption. And you can see from the 1900s through up to the first smoking cancer concern in the late 40s, 1950. In the 1950s, that was the first dip, a little bit more of an increase, and then finally over time you can see the trend, the downward trend. And what's posted here are the things that scholars who have looked at tobacco, and it's not my area, but they've identified things that they think are underlying those changes in the trends. And so we can just take a minute to look at some of those. So for example, the one in the 50s where they first started thinking about the cancer concern related to smoking, you can see a little bit of a dip, but then not so much. It didn't stay down. And you see another increase again until the first Surgeon General's report and the first World Conference on Smoking and Health, which really tried to get that cancer concern message out there. And then you see changes in the media environment, where there was the broadcast ad ban came after TV and radio were required. If they were going to do advertising on tobacco, they had to also do public service announcements to counter those advertisements, till finally there was just a broadcast ad ban altogether. And really, one of the things that people say was instrumental, you see down here in like around the 1970 with the non-smokers' rights movement that began at that point. And what happened with that, you may remember, or you may not have been born, some of you, by then. It was really when we stopped talking about the individual smoker and the risk to the individual smoker, and that was our sole focus, where it was changed more to your smoke affects my health. And I don't like it. So once there was the evidence of secondhand smoke and people started reacting to that, you can see that the trend really started heading downward. Also importantly was the federal cigarette tax, and that made it a lot more expensive for people to buy cigarettes. And finally, the Master Settlement Agreement, which really caused the tobacco industry to part with a lot of money in terms of the damage that they had done. And calling out, I think, it was a combination of a lot of that money went to educational campaigns and marketing campaigns, but it also did something else that's really important, I think, when you talk about changing behavior. It changed the argument. It changed the context of the argument. And by that, I mean, it really shifted our whole paradigm from smoking cessation and getting smokers to quit to talking about controlling the product, tobacco control, and looking at the industry that was underlying both starting smoking and quitting smoking. And if you generalize from these two examples, what we really talk about in terms of trying to change behavior is how do you change individuals and change their environments. So it's not sufficient to think about just focusing on the individual without appreciating their context and the environmental influences on their behavior. Does that make sense? Yeah. Does anybody see any examples of that today on a different health topic? In gun violence? Can you say more? Where? Mm-hmm. Exactly, and really trying to change the policy environment and putting more restrictions on access to guns. Exactly. Any other examples? I'm sorry. Go ahead.
Promoting safer sex practices in social networking venues. So when people are no longer meeting in a bar where condoms are available, but they're meeting online, where it's hard to create an environment around safer sex, there's been an uptick, at least in my experience, in unsafe sex practices. So how do you define a social networking site as an environment and make changes to that to promote safer sex practices?
That's a great example and really very modern, very contemporary. Yes, it's a whole new world out there. Yeah. And somebody over here had a comment? I heard. Uh-huh. New York soda ban. Yes, exactly. I was thinking about obesity as another example, and all the debate now about the food industry as the player to focus on. That's great. Okay, great. So you all are ready to solve all the new problems. So if we then ask what underlies the ability to be successful at changing environments and changing behaviors. Again, people who have studied these and other examples sort of concluded that our approaches need to really be comprehensive and multidisciplinary. We need government leadership. We need a sustained commitment to research. Every single example that you can think of, you're not going to, your first step has to be, what are the data telling us? What is the evidence of the problem and of effective solutions? So sustained commitment to research is important, and then advocacy and public support also has been critically important in all of these successful movements that we've had to improve public health. And these actually, another reason I like this slide for this particular talk is because this is how we approach education here in terms of training public health professionals, and what you want to do with your career afterwards, whether you want to be in government and be a government leader, whether you want to do research and advance the science, whether you want to do advocacy. These are the tools in your toolkit that you'll have after coming through the program here, because this isn't just how I approach health behavior, but this is how public health approaches solving public health problems in a large measure. So in terms of this kind of approach, what do we call this kind of approach? Well, we basically think about it as an ecological model because we're talking about an individual within their larger environment. And there have been 3 major reports that have been landmarks for people interested in health behavior because they've come from such prestigious places as the Institute of Medicine and the American Public Health Association and the American Psychological Association. And all of these sort of advocacy, professional organizations, and think tank type places have really looked at these problems and concluded consistently that we really need to take this kind of ecological approach. And they talk about how health and well-being are affected by this dynamic interaction among biology, behavior, and the environment. We see that clearly with the tobacco example, which if you noticed in that downward trend side, the nicotine patch and other medications came along. So it was giving some biological, if you will, help to the idea of getting people to quit within all the other things we talked about with regard to behavior and the environment. And the point is that when you're trying to be a change agent, you really need to understand that the interactions of these things change over the life course of individuals, families, and communities, and it's not static. And if you like diagrams better than words, this is a picture of what I'm trying to explain, which is that the individuals are at the core, and then all of these other factors influence their health and well-being. And those things change depending on whether you're an infant, a toddler, or an older adult, or whether your environments change, whether you are in a low-income urban environment, moving to a suburban environment, to a rural environment. These things will affect you differently. Your social relationships will be different, your living conditions, your neighborhoods, etc. So again, this is an important sort of way of thinking that we try to espouse in terms of thinking about how to improve public health. So that's the second part of what I wanted to talk about. And I think the last thing I want to cover is how can we help ourselves and help others change behavior. So usually we're over there on the left side building our programs or our interventions, and we're over on the right side, we're hoping for a public health impact. But the problem is we think in the middle a miracle has to occur, right? So I think you should be more explicit here in step 2. So from a health behavior, now I'm switching in back to behavioral sciences. When we think about changing behavior, what we think about is how do we avoid having to rely on a miracle to occur. When we build our interventions, whether they're policy or program, why do we think they're going to get us to some kind of outcome? And so I'm going to answer that question with a few basic principles that that may be familiar to some of you. Maybe they're often common sense to all of us. But in order to do that, I need your participation. If you would indulge me for a minute and stand up, that would be great. I know you need to anyway, right? It's almost time for lunch. You need a break. So, okay. So you can remain standing if you wear your seatbelt on every ride. Usually keep most people on that. If you always eat food that you think is healthy, usually lose most people on that. Oh, come on. If you do, you do. If you exercise regularly. And if you drink alcohol only in moderation. Oh, or not at all, I should say. And you floss your teeth every day. Okay. Well, you all get a round of applause for participating in that. And if I had a chair, I would have sat down, but I'm not telling you at which one. Although you can probably guess it's the exercise. So why did I do this? I didn't do this to make you feel bad about the things that you don't do regularly. What does that illustrate in terms of behavior change?
It's hard. It takes a long time to get it right.
It's hard? That's true. That's right. We all can improve in different ways.
Sometimes there needs to be a catalyst to make the change. You don't have any real reason to follow any big things. I mean, other than the first, which is the law. Otherwise, sometimes needs to be kind of not a mandate, but some reason that you have.
So the motivation to do these things is variable, and you need something to support you in doing it.
It takes more than just knowledge because we all know we should do these things.
Yes, from a behavior change and a behavioral science theory, that's exactly the point. Is there's nothing on this slide that you haven't heard about as necessary, right? As important to do for your health. But the problem is when we do our behavior change programs, we somehow forget that, and we think that, oh, if I just tell people that this is good for them, they will do it. And that's why we get lots of really ineffective messages and ineffective programs out there. So it's a very, very basic, fundamental principle of health behavior change interventions. Information is necessary but insufficient for behavior change. So if we want to communicate well with people, obviously they do need the basic information, but they don't need to know everything we know. They need to know what's going to, as you point out, motivate them to consider making a change. And one of the problems that we have is that we fail to recognize often that literacy is an issue. So when we try to communicate information about health, we need to take into consideration whether people can read, write, and understand what we're communicating. And it's important to know that more than 40 million people in the United States, adults in the United States, read at or below the 5th grade level. An additional 25% read below 8th grade. Other folks in the field have done a couple of studies that show, at least in the area that I work in pediatrics, car seat instructions are written at the 10th grade reading level on average. And in a survey of print materials for parents in a pediatric office practice, 80% were written at a 10th grade reading level. So while information is necessary but insufficient, once you get into delivering the information, please pay attention to the literacy level of your audience. So the other thing that is important in terms of this idea about principles and theories about how it is you think your intervention is going to make a change is that there are lots of tools that you can use, both theories and strategies. And what this chart shows is, remember, we're talking about changing people's behavior and changing the environment. And so what this shows is that there are strategies for each of those along that whole continuum, and there are useful theories along those continuum. So if we think ecologically, we're thinking in the middle there about the individual. Interpersonal, which was a great example of the social networking online, how do people interact with others who can influence them, and then the larger community, how do we work at the community level. And so obviously I'm not going to go through all of these, just to tell you that this is the kind of information that you would be getting in the classes that focus on health behavior change. We talk about all of these theories, not just from an abstract perspective. There's a quote that there's nothing so practical as a good theory. So we really try to apply these notions about how to help people change, and we need to understand the theory to do that, but only in the sense that it helps us decide what kinds of strategies do we want to use and how do we want to use them. I will share one thing with you, though, is that even though there are probably as many behavior change theories as there are, people in the room, there actually are some that have the most rigorous literature behind them and the most experience behind them, and they're listed here. And the thing that's interesting about it is when you get the people together who create these theories, they decided that there are really only 8 common factors across all of these theories. And so if you're trying to build a health behavior change program, you really only need to understand those 8 factors. And those 8 factors are listed here, and I'm not going to spend time going through them because I want to give you another example of some of the work that we do in behavior change here. But if you think about your own behavior, or if you think about a family member or a friend whose behavior you're trying to help change, think about the first 3 things. You have to have them get a positive intention. You have to help them want to change. Then there can't be any overwhelming environmental barriers, and they need to have the necessary skills. I mean, a perfect example is eating healthy in a very low-income urban environment where people might not even have the information to know about how they are supposed to be eating or could be eating to improve their health. Even if they do know that, they're living in food deserts where they don't have access. That's an environmental barrier. If they have access to healthier foods and it's a brand new thing for them, do they have the skills to prepare healthy foods in a healthier way? So it's again, what I like about this area is a lot of it sounds like common sense, right? And you get to be creative, and you get to try things that might make people a little healthier. So those are the big 3. That's what you need to think about. And I'm going to go through an example of work that we're doing in childhood injury in Baltimore City, which I hope will illustrate a little bit of these principles or theoretical constructs that we've talked about. Does anybody have any questions? I go through this last thing.
How large of a change is this? How big of a behavior is this?
Mm-hmm.
How small of a behavior is this?
That's a great question. So how does the role of the complexity of the behavior fit into these issues? Well, I think the complexity of the behavior makes it even more important to work through all of these kinds of issues and figure out whether you can break the behavior down into more specific components so that people generally can have some success. So I think the complexity of the behavior comes out in each of these. I think the most obvious example might be the last one, believing that you can do something, self-efficacy, your confidence. And what they say with that is when you have a really complex behavior, it's important to break it down into its component parts so that people don't feel overwhelmed by it and they can get some confidence that I can do this step and this step and this step. So there are ways that complexity plays out in all of these, and it's really important.
Is there a way that researchers might say, okay, we achieved the seatbelt change and that's important, but that was simple versus some of these other behavior changes we're trying to actually do is more complex. So even though we're comparing it, it's like apple and oranges kind of thing, right? It sounds like right now the way we just talk about smoking, seatbelts, all these different things, it's like they're all just behaviors, as if they're all in one category of behavior. But do researchers ever say, well, yeah, you got everybody to do that, but that's really easy compared to this?
Oftentimes that is the research question. So, for example, if you picked a particular theory like stages of change, you would say, well, so stages of change, which says that people change in small increments over time, they have to become aware of something before they're going to take action, and then they have to practice and so forth. So that whole theory evolved out of smoking cessation and studying how people quit smoking successfully. and they developed a theory. So now other people will say, well, my behavior is really a little like smoking, or my behavior is not like smoking, but maybe this theory will work for it. So I think if you can find lots of literature that explores the question just the way you asked it. Yeah. Anything else? You going to do a dissertation here? You got your topic.
I have other topics.
Oh.
But this is relevant.
Oh, good. Okay. So the burden of childhood injury in Baltimore City is the example I want to give of how we built a program using some of the things we've talked about. So it's important to know that unintentional injuries is the leading cause of death for ages 1 to 14 in Baltimore, divided up between fires and motor vehicles. Our kids in Baltimore were 4 times more likely to die from a residential fire than kids nationwide, and children younger than 5 in Medicaid managed care experienced injuries at a rate that was nearly twice the national average. So our health commissioner, now he's our commissioner of health for the entire state, really realized that the data, remember starting with the data, were compelling to address this problem. So we developed something called the Safe Home Project, which was a collaboration with the Johns Hopkins Department of Pediatrics, our injury center, and it was funded by the Maternal and Child Health Bureau and private foundations. And I'm just going to walk you through it very briefly to give you an example of how we tried to work on changing behavior and changing environments. So I won't bore you with all the needs assessment and the formative research and the theory and all of that behind it. What we ended up with, I just saw this. Let's see. So what we ended up with was trying to address these particular safety behaviors of parents with children from birth to 2 years old, so infants and toddlers, in a low-income urban clinic here. And we tried to address increasing the use of smoke alarms, cabinet locks, safety gates, and having safe hot water temperatures. We also were working on to increase the use of syrup of ipecac, but if any of you are medically oriented, this is no longer recommended by the American Academy of Pediatrics. It's used to induce vomiting for some kinds of poisonous swallowing. Ingestions, thank you. Yes, so anyway. And we did that by improving the pediatric counseling that was provided, establishing a children's safety center, and conducting home visits. So these were our 3 intervention components. And remember I said a miracle occurs in the middle? We actually built these 3 interventions based on our assessment of these characteristics of the caregivers, which was assessing their knowledge, beliefs, and skills around these child-proofing behaviors, what social support they had, and in terms of what the pediatricians were doing to help them, and then if they had access to resources to actually get safety gates and cabinet locks, etc. So that was our logic, our simplified logic model. And the pediatric counseling was a 5-hour training program that was led by pediatric faculty with hands-on practice. So a lot of these pediatricians in training were young and didn't have experience with raising their own children, and so when you asked them to install a stair gate, it was quite perplexing. So we actually gave them stair gates, and they learned how to do what it was they were recommending that their parents do. And we did role plays of effective counseling and gave them homework. And the counseling framework we used was based on sort of what do we know about effective one-on-one counseling that facilitates behavior change. And it's soliciting information, so you give information that people need, not information that they already have. You provide tailored advice. You focus on the risks and benefits of doing the behavior, and you encourage compliance. So this was the training that we did. For the pediatric counseling component. Then we built a children's safety center where we provide free personalized education and low-cost safety products, because our families told us that they'd love to use a stair gate, but they don't know where to get one, and they don't have any discretionary money to buy one. So we made it part of the clinical visit. And then we conducted home visits to see if sending a community health worker into the home would help parents do the child-proofing behaviors. And those, as I said, were the 3 interventions. We did a pretty complicated study design to evaluate this, and in the interest of time, I'm not going to go through the study design. I'm happy to talk about it later if you want to know more about it. I'd rather just tell you the punchline. So the punchline was that the training program for pediatricians actually worked. We got the pediatricians to provide more and better counseling about injury prevention. We did that by listening to audio tapes and randomizing people to get the training or not get the training. And then we evaluated the patient outcomes, and we found that patients were more satisfied when their doctors talk to them more about their children, which is great. If you're running a clinic, you want satisfied patients. But if you're in injury prevention, we were a little disappointed that it didn't have any effect on their safety practices at home. So again, information necessary but not sufficient. When we combined the pediatrician counseling with a visit to the Children's Safety Center, we found that parents actually did do more safety practices at home, more childproofing. And the home visit from the community health worker had no added benefit. So that was many years of work. The Children's Safety Center still exists. It's 20th year? I don't know, 15? It's many, many years. So the hospital liked the results, and they decided that the Children's Safety Center would now be a service program of the hospital, and we continue to run it in a partnership with them. But we realized that families don't all just come to Hopkins, so we needed to take the show on the road, and we took the model of access to products, personalized education, and we partnered with the Baltimore City Fire Department to build the Mobile Safety Center so that we can go to communities and provide those same services to people. Basically, it has interactive educational exhibits here for all these home injury hazards. And the really fun part is when the fire department does the bedroom, where the bedroom fills up with fake smoke after they've taught the kids what to do when they hear a smoke alarm go off, and then they get to practice that. So that's another project that we're currently doing, again, as a service program that we embed in research projects to answer interesting questions to us about how do we help families do a better job of protecting their children. So to summarize, I hope what I wanted to try to convey is that behavior is clearly an important contributor to public health problems. Behavior change theory and methods and principles can help contribute to developing solutions. There are multiple successful examples of how to change behavior, and in in every case, comprehensive approaches really are needed to change behavior. And so I hope that you take those messages away. And I guess the last point is that it takes a lot. 2 great virtues in life are patience and wisdom. So I wish you patience and wisdom, and I hope you enjoy your time at Hopkins, and that we'll see you in some of our classes. So thank you very much.
One of the biggest problems I looked at early in my career was that of little kids in cars. I was working in the medical examiner's office. We'd see the bodies that came in from crashes, and perhaps the most tragic were the little kids and the babies traveling in their mother's arms, unrestrained. Nobody was doing research in this area. We saw a need for a center where we would have colleagues doing good research together that would help to prevent injury. The Centers for Disease Control and Prevention agreed with us, and they funded us to start the center. That was 1987, and we haven't stopped since.
So we've done a lot of research in the past that described what happens after you've suffered a very severe injury. And what we found was the trauma surgeons do a great job of putting people back together. And yet, in the end, trauma patients and their families needed support for not just the physical consequences, but also the psychological consequences from a traumatic event. Post-traumatic stress, anxiety, depression are all very common consequences from a severe injury. So we worked closely with the American Trauma Society and some of the leading trauma centers around the country to build the Trauma Survivors Network, a program that helps injury survivors connect and learn from each other. Just having somebody who knows what they've been through makes a huge difference. We need to get the Trauma Survivors Network running in every trauma center around the country.
Standing emergency. My mommy and Daddy are having a fight. Stop it! Mommy!
Okay, don't cry. We're going to send the police.
Okay.
It's a simple questionnaire, 11 questions that police ask victims when they respond to a call for domestic violence. If the victims answer affirmatively to certain questions, the red flag goes off, they're in high danger. It's a relatively simple assessment. The officer can immediately connect the victim to services that could help save their life. We're collecting this data to both evaluate and improve the program so that other jurisdictions that are interested in implementing the program can use it effectively. We're connecting research to real life.
We care about keeping kids safe. No one ever wants to interact with a family in the emergency room after their child's been injured. But it's our job to help those injury prevention messages resonate in a way with families before the event.
We're gonna learn about safety.
The Mobile Safety Center is basically a 40-foot truck where we've designed the inside of it to look like a common home. For instance, we take a normal-looking stove and point out the hidden injury hazards to a parent and to young children. Not to freak them out, not to scare them, but to educate them so that they can properly protect their children.
Or even a candle. Do you touch that? You never touch any kind of fire. Well, it's a great tool to teach families how to keep their homes safe for their children.
It's a model that we started here and is being replicated all over the world.
The center began very simply with one pioneering epidemiologist by the name of Sue Baker.
We've accomplished so much, and I'm just proud of what we've done.
We've changed laws, we've encouraged people to find new ways to protect themselves, and we've really changed the culture of safety. You can immediately see the impact of your work on the lives of real people. We're also very committed to training students as part of our core mission. They will be the ones who will know how to solve the injury problems of the future. Trying to prevent fires and burns, trying to find new ways to reduce distracted driving, trying to help older adults not fall in their homes, trying to find ways to make our neighborhoods and streets safer.
We're talking about something that's a health problem for almost every family. Injury causes more lost productive years of life than any disease, much more than cancer or heart disease.
So it's not just about telling people to be careful, it's about working together to find ways to solve the problem.
So welcome back. These videos that we're showing you, obviously we don't have time to show you all of our videos that we have, but these are just small glimpses into what's going on and kind of what you have to look forward to as students here at the Bloomberg School. So I hope you've enjoyed them, and just go onto our website and you can view about 500 other ones. Moving on, we're kind of shifting gears now. I hope you all enjoyed your seminar series. We're going to be hearing from Mindy Levin, who is the director of SOURCE, which stands for our Student Outreach Resource Center, and you've heard mentioned earlier this morning. She's going to tell us a little bit about SOURCE, and then we're going to go into a panel discussion where several of our current students will be here to answer questions. And this is your time to ask those questions again, and they're here to tell you about their experiences and things like that. So without further delay, here's Mindy.
Good morning. How's everybody doing? Okay, great. Well, welcome here to Johns Hopkins Bloomberg School of Public Health. Out of curiosity, how many of you are from Baltimore? A couple of you, raise them high. Okay. I'm also a Baltimorean, but I just wanted to point out folks around you that also know our city fairly well if you're from Baltimore. People that are here from the state of Maryland. Okay. And everybody else that's not here from Maryland, which is most of you. So welcome. So one of the reasons why they have me give a presentation about SOURCE is to talk a little bit about how our school is very involved in our communities and to give you a better sense about what it's like to live here in Baltimore. And I am a Baltimorean. I'm born and raised here, so I'm happy to go into some more details about our fine city. So first I'm going to talk about SOURCE. I'm really excited to hear that somebody mentioned us this morning. That's great. SOURCE, as Leslie mentioned, Student Outreach Resource Center, we are the community service and service learning center, not only for the School of Public Health, but also for the schools of medicine and nursing. So all three of our health professional schools that we have here at Johns Hopkins. And we're all located right next door to each other on this particular campus. And the main thing that SOURCE does is that we really encourage our schools to work in the community through a variety of settings. If you're a person that's really interested in community engagement, CBPR, service learning, I encourage you to take down our information. Much of what I'm going to say today is on our website, and you can find a lot more information there. So again, as I mentioned, what we do is really to get our students out in the community, and there's a lot that we do in terms of collaborating with some of our local nonprofits and other public health agencies right here in our city. And so there's a number of reasons why we encourage our students and our schools to be engaged in the community. One of the things that's really exciting is that you have an opportunity to learn a lot about theory here in the classroom, but we give you an opportunity to apply theory out in the real world and have a live practical experience. I can also tell you that our nonprofits that we partner with actually rely on our students to come and work with them. So with the economical times that we're facing right now, some of our nonprofits are short-staffed, and they actually are like, when do your new students start? We're ready for them to come. So they're actually eagerly awaiting new students to come and arrive here in Baltimore. When you hear about, building your resume and networking with other professionals, we're giving you that opportunity to be working side by side with public health professionals in the field. And because so many of you are not from our city, here's an opportunity for you to make a difference and contribute in a meaningful way. Now, I will say a little bit about Baltimore, and that is we are not unlike other cities around the country and around the world. These are just some of the health challenges that we do face here in Baltimore. We have high rates of diabetes, hypertension, obesity. Of course, substances are an issue. And then based on the last census, the 2010 U.S. Census, we know that 15% of Americans live below the poverty line. Well, when you look at the immediate area surrounding this campus of East Baltimore, that rate is actually even more alarming, where we have 29% of East Baltimore residents that are living below that poverty line. So there certainly are issues that we're working on here in our own city. Now, why I say that there are issues, I also want to let you know that we have tremendous assets right here in Baltimore. And what SOURCE does is that we partner with about 100 nonprofits in Baltimore City. And we do solely focus on Baltimore City. We do that intentionally. I mean, again, when you're working here at the School of Public Health, we are on a quarter system. So the terms are pretty quick turnaround. So oftentimes you don't have as much time to be out and engaged in the community. So we want to make sure that you can do things kind of conveniently nearby. And we also have an opportunity to make a real impact. So the types of organizations that we work with are extremely broad. So regardless if there is a particular health topic that you want to focus on, if there's a particular population that you'd like to work with, you will likely find a nonprofit within our network of partners that you can work with. And one of the things that we have that's available on our website is that we do have a directory of all of our partners, so you can take a look at any time just to kind of get an idea of what some of the partners are doing here in Baltimore. Now, when I say that we're the Community Service and Service Learning Center, I think it's really important to understand that that means that we are engaged in Baltimore in a number of ways. So I'm going to kind of breeze through just a few ways that you can be involved, but this list is not encompassing everything. We have the standard volunteer positions, whatever you want to do and go out there, work in the community is nothing connected to academics whatsoever. But we also have internships. And whether it's because you're doing a required internship, like for a MSPH program, or if you want to do an internship for special studies and get a little academic credit, we do have links directly to academics. For those of you that might be coming here and doing an MPH, we do MPH capstone projects and practicum experiences with community partners here in the city as well. For those that qualify for federal work study, we have a number of federal work study positions that are out in Baltimore where you're actually outside of the school and working in the community. And Source also will have openings in our office. We usually hire 3 or 4 work study students per year, so be on the lookout for that. Then it also has, it depends on like what your time is. How much time do you want to give? So we always give opportunities for students and faculty, staff, and alums as well to work in the community for one-time projects. And we also have short-term projects through our Connection Community Consultant Program, where we have small teams of students working on short-term projects. And then we also have more long-term projects that you're doing out in the community, whether that's CBPR, community-based participatory research projects, or if you're working on a service learning course. So one of the great things about our office is that we do work with a number of courses here in the school where we give you an opportunity to work with a community partner for a deliverable that's directly related to the kind of objectives of your course. So you'll see us pop up in a lot of courses to say, for example, welcome to the Qualitative Research Course Series. We come in and say, here's some opportunities for you to work with organizations that are looking for some qualitative research opportunities. So it's a really great opportunity to engage and increase your learning as well. Outside of these involvement opportunities, we also host a number of different programs and special events throughout the year. When all of our students are here in mid-September, we basically hold our annual Source Community Involvement Fair. And this is where we invite all of our partners to campus, and you get to learn about the various opportunities for you to participate with community organizations, from the internships and work study and service learning courses. And then in early October, usually the very first week in October, we host Baltimore Week. And we've been doing Baltimore Week. I think this is going to be our 8th year of hosting Baltimore Week. And we're very intentional about that as well, because oftentimes, so many of you raise your hand, you're not from Baltimore. The only thing that you know about Baltimore is from what you've seen on The Wire. And so we want to paint the picture of, life beyond The Wire here in Baltimore. Again, there's tremendous assets and wonderful things that are happening. And as a matter of fact, when we have students that really look and explore the city, people love Baltimore, which is why one of our nicknames is Charm City. Some of the other things that we do, we hold community tours. And our community tours, we basically go around and show you where a bunch of our different nonprofits are and tell you a little bit about the city and the history and the health issues that are going on. We do a lot of those around orientation time. And every single term, we host some kind of large-scale donation drive, whether we're collecting toiletries or canned foods, things that we're giving back to the community. Right now, it's April, so we're actually quite busy with activities. Gearing up for National Volunteer Week, we give away our Source Awards, which go out to students, student groups, community partners, and faculty members that have excellence in service learning. And much of what we do is also in collaboration with other people. Obviously, you've heard me talk about the community partners, but there's also a lot of student groups on campus that do a great deal of work in the community, and we advise them and connect them. And we also do a lot of work with the various centers and departments on campus. Bring in our experts who know Baltimore best, and those are the citizens that live here and have been, kind of running the show for many years. Now, if anything that I've said so far has really sparked your interest in Source, I encourage you, you have your smartphone on you, pull it out, send us an email, subscribe to what we call our Source Weekly Service Scoop. It's our newsletter that we send out just once a week, so we don't, kind of stalk you via email, but just once a week, the latest involvement opportunities. And then, of course, we're on Facebook and Twitter and LinkedIn, so you can connect with us there as well. But let me turn my attention to the next part here, which is talking a little bit more about my city, Baltimore. And I'm going to focus a little bit on these particular areas, dialect, kind of highlight some famous folks from our city, talk a little bit about transportation, entertainment, shopping, living in Baltimore, and then towards the end of my remarks is when I'm going to bring on 6 fabulous panelists, which are some of our current students that are all living in different neighborhoods to kind of give you a sense of life in Baltimore and the neighborhood's various communities. All right. So let's talk about our dialect. So when you meet people from Baltimore, oftentimes there are some of us that have a very distinct dialect. So when we talk about our city, you might hear somebody say, I'm from Baltimore, Maryland. And we say Balmer instead of Baltimore. And sometimes you might hear us say Maryland instead of Maryland. And then we'll also, about now, it's because it's springtime, it's starting to get nicer out. I might be talking to Leslie and say, hey, hon, when you going down the ocean? And what we're saying is, Leslie, are you going down to the ocean, meaning Ocean City, Maryland, which is a popular vacation resort. Now, you will likely be greeted by somebody, and somebody, whether you're male, female, or whatnot, they're going to call you a hun. And it's a good thing. It's short for honey. It's just how we talk to people. Welcome to Baltimore, hun is kind of, again, an unofficial motto of our city. So we say that it's short for hun, but it's also how we describe certain people. And these ladies here are what we describe as huns. Now, it's important to note that Baltimore is like a city filled with neighborhoods. And these neighborhoods have complete distinct personalities, one from the next. And one of the cool neighborhoods that I like is Hamden. And in Hamden, every June, they have Hun Fest. And literally everyone and their mother, their kids, their dogs, their cats are dressed up in Huns with the beehive hairdos and sunglasses, real kitsch. And so it's a really fun kind of area. So you'll meet some Huns. Okay, so because we're on a medical campus, oftentimes you're going to hear an ambulance go by. Sometimes we forget a syllable or we'll add in extra R's to certain words. So like if your clothes are really wrinkly, you might iron instead of iron, or we might wash your clothes instead of wash your clothes. And then this is the O's, the Oreos, which is actually the Baltimore Orioles, our local baseball team. Now, famous Baltimoreans. This list does not include everybody. Every single time I give this presentation, someone in the audience sends me an email and says, you forgot so-and-so. I know, I don't have them all enough time. But anyway, these are just some of the famous Baltimoreans that have come, born and raised in Baltimore, that we're quite proud of, whether they're filmmakers or athletes or politicians or musicians or, the list goes on. And of course, I just wanted to highlight that this is a city that's filled with some fabulous people, and we hope that you become one of those additional rising stars. Now, another great thing about Bloomberg and where we're located is that we are well connected to political leaders throughout the state and very close to the country because we're so close to DC. And so I wanted to just feature a couple of our local leaders. And the great thing about these local leaders is that they so often are roaming the halls and appearing in classrooms and giving lectures that you have an opportunity to literally have conversations with these folks and potentially even work with them. So from our Governor O'Malley to Lieutenant Governor Brown, then you see our Mayor, Stephanie Rawlings-Blake, and our City Council President, Jack Young. And then on the very bottom is our City Health Commissioner, Dr. Barbeau, who's been with us for about, I think, 2 or 3 years now. She came from New York City. Okay, so getting around Baltimore. So we don't have the best public transportation, but we do have decent public transportation, and the options continuously improve. One of the other great things about Hopkins is that we happen to be the state's largest employer. So pretty much wherever you live in the surrounding counties and throughout Baltimore City, there's public transportation that comes here because they're going to Johns Hopkins Hospital. So you can get here very easily. Hopkins does have a very elaborate free shuttle system that connects our undergraduate campus, which is the Homewood campus, to here. We also have an Eastern campus and a Mount Washington campus. And oftentimes, students, faculty, and staff live somewhere along that Hopkins shuttle system because it's your free ride to work every day or free ride to school. The other great thing about Baltimore is that there's actually a great number of colleges and universities in the city. And we do have an organization called the Baltimore College Town Network. And the College Town Network actually has what they call the College Town Shuttle, which actually connects the different universities in Baltimore. So you can potentially take a course at another college or university or a friend somewhere else and easily get there. And these are free shuttle services to take advantage of. Now, other options that are not necessarily free, we do have the subway as well as the light rail. We do have Amtrak and the MARC trains. Some of you might have pulled into Baltimore's Penn Station this morning. Our shuttle service, our free shuttle service, does pick up from the train station there. So anytime you want to travel that way. We have very extensive bus lines throughout the city. And then we also have something that's relatively new. It's been around for a couple of years. It's called the Charm City Circulator. And there's about 4 bus routes throughout the city that are free and green. And one of them actually comes here. Again, state's largest employer, get around town free and very easily. We're very close to the airport, BWI airport, and we also have fun water taxis. And if you come here without a car, we also have zip cars that you can rent as well if you need to do it occasionally. Now, entertainment, there's tons to do. This is just a quick glimpse of some of our galleries and museums that are in the city. The picture on the top is the American Visionary Art Museum, and the picture on the bottom is from the Reginald Lewis Museum of Maryland's African American History and Culture, which is, I think, probably about 6 years old now, and fantastic museums. But, you know, you can see great variation of things, whether it's sports that you're interested in. We have a dime museum, literally the coin, all kinds of funky, weird things, a pinball place. So lots to get around. Now, theaters and concerts, whether you want to see a live show, whether you want to be in a live show, or if you want to go check out a movie. Again, these are just some of the options that are available. The top picture is the Creative Alliance at the Patterson, which is on this side of town in East Baltimore. And then the picture on the bottom is of the Hippodrome, which is on the west side, and that's where a lot of the Broadway shows come and play here in Baltimore. The other great thing about Baltimore is that we happen to have a ton of different unique community-oriented festivals and events that go on. The picture at the top is from the annual Kinetic Sculpture Race, where tons of people put these sculptures together, they race them through town, they put them in the water and see who, you know, keeps their contraption together. And then the picture on the bottom is from our Miracle on 34th Street around the holidays. Just gets a ton of traffic over there to see this whole block just completely lit up. And then the great thing, my favorite time to be in Baltimore is actually in the summer, where there's just a slew of cultural festivals like every single weekend. So a lot of different culture, great food, and free entertainment for all. I do have to mention shopping. Again, we have decent shopping in Baltimore. We're no New York City or anything like that, but we are not too far from like DC and Tyson's Corner and some other like fantastic shopping. But we do have a lot of different local shops here. And then we also talk about if you need to get food. So there's a Whole Foods here in Harbor East, which is not far from campus. There's a Wegmans to the north of us, but there's other Wegmans that are popping up all the time. But there's also a ton of different farmers markets around town as well. So some of the neighborhoods that I've highlighted on the bottom tend to be popular neighborhoods because of their location, free shuttle service. Oftentimes they're connected to campus, but they also have a lot of the restaurants and kind of local shopping that you can do as well. So food and dining, I'm a huge foodie, and no matter what you eat, whether you are vegan, vegetarian, or, you know, complete carnivore, you can get everything under the sun from every single cuisine. One of the things that we're known for in Baltimore is seafood. So if you do partake in eating fish, you have to crack open some crabs and throw back some natty bows. It's just what we do here in Baltimore. The other great thing is there are tons of wonderful coffee shops around town. So a lot of times students and faculty are just kind of hanging out at coffee shops and studying and just kind of conversing. So there's a slew of things that you can eat in Baltimore. And we are also having that whole food truck thing going on here in Baltimore. So they pop up here on our campus, which is wonderful, but they also have food truck gatherings so you can, you know, eat your way through anything that you want. Okay, I have to talk about Baltimore being a huge sports town. If you don't know it, the Baltimore Ravens are your world Super Bowl champions. That's me inside, you know, in New Orleans. Just happy that I'm a big winner. Today is an important day. If you don't know it, today is opening day here in Baltimore for the Orioles. So we bleed purple and we bleed orange, so just get used to it, especially if you're from Pittsburgh. Now, if you also, I've listed some other sports that we kind of care about too. There's other things, right? But oftentimes we also have people that you want to play in sports. So we have a couple of social leagues that go on, and oftentimes our students will end up having, you know, the Bloomberg MPH class of 2014 is playing in the dodgeball league, okay? So there's great ways that you can get out there and be active in the city as well. Baltimore, our location cannot get better because, for one, if you wanted to explore all of Baltimore and all of our neighborhoods, you could not do that in many weekends. But if you also wanted to get outside of Baltimore, we are a hop, skip, and a jump from many of these places. We're like 40 minutes from DC, 3 hours from New York, an hour and a half from Philly, about 2.5 hours from Ocean City, and the list goes on. One of the other great things about the state of Maryland is that Maryland is often referred to as mini America. And that's because we have all of the geography. We have oceans, we have mountains, we have beaches. So anything you want to do outside, we have it right here in Maryland. All right, so housing, I know you have information about housing in your packets, and you're also going to be hearing from our panelists, so I don't want to go into too much details here. I just listed some of the different websites where you can find out about housing. We do have our own housing office for the medical campus. Oftentimes people are posting classifieds within our own Hopkins Gazette, which is our monthly magazine, and the city papers as well. And again, you're going to hear some of these neighborhoods mentioned from our panelists. And I'm only promoting these because they're popular, where a lot of our students, faculty, and staff live, and again, oftentimes because close proximity to our shuttle system. All right, the other things that I'll quickly mention before we bring up our panelists are other resources that we have. So if you are coming to Baltimore and you're going to need to find a place of worship, we can connect you. There's a lot of different resources that can find, people that you want to connect with. If you're coming here and you have children or you're going to be having children, we can help you with childcare and point out, great schools and all that kind of good stuff. And then it's also nice to know that while Baltimore is not completely green, we do have great numbers of parks here in our neighborhoods where you can, kind of get your time out there with nature. Some other resources just to know about, there's a great organization called Live Baltimore, and their website actually has information about all of the neighborhoods, and it'll have statistics about them. It'll tell you a little bit about their characteristics, so it's just kind of a cool thing to look through to get a sense of the different neighborhoods. Our city paper is free. It comes out online and, on the newsstands every single Wednesday. The Baltimore Sun is our local newspaper. The Urbanite magazine, which pictured on the bottom, is a monthly magazine, and oftentimes you find editorials in there by some of our students as well as our faculty. And then, of course, a couple of those other entities that I've already mentioned, like the Baltimore College Town Network. You can find out a lot more about Baltimore. Okay, so I think I'm right on time, and hopefully all my students are hanging in the wings. So feel free to talk amongst yourself. We'll bring them on up to join us on stage. Hello. Hi. Come on up. Come on up, guys.
Oh my God! Okay, so you're good. Like a team wants to come talk to you.
All righty. So I'm going to go ahead and get started because we want to make sure we have time to talk with you all. What I'm going to do, let me first set the stage a little bit about Baltimore. I do have maps here, so we'll kind of be pointing out the different neighborhoods where the students are going to be talking about where they live. So this is not all of Baltimore City, but let me point out, I think I have a clicker that works. Okay, there we go, perfect. So on this map here, this little blue smiley face, that's us here at Bloomberg. Then you see these two red lines. So this red line here, this is Baltimore Street, and Baltimore Street is the street that divides our city between the north side and the south side. And then this is Charles Street, which is one of our main streets as well. And Charles Street divides the city between the east side and the west side. So some of us that are here from Baltimore, we just kind of know where we are in relation to these streets. So I might say, Jacqueline, I'm going to meet you on the northeast corner, and we'll know what that means. Okay, so this is what we're going to do. I'm going to have each of our panelists introduce themselves. This is what they're going to introduce themselves. They're going to say their name and your degree and or department. They're also going to tell you what neighborhood they live in. And then I'm going to give them each about 2 minutes to talk briefly about your neighborhood and what you like about your neighborhood, the area where you live. But can you also include like what type of housing you live in? So if it's a row home, and this comes up a lot. People always ask, well, how much is it? So if you are willing to share with us how much you spend, if you have roommates or not. And then that's it. After that, we open up to you guys. The rest of the time is for Q&A and kind of ask all the questions that you have. So I think there are microphones. Jelani has you. Okay. So Jelani, I'll start with you on your side because I'm looking at you. So Jelani's going to introduce himself and tell us a little bit about where he lives.
So, good morning, everyone. My name is Jelani. I'm a current master's student in the Department of Health Policy and Management, an MSPH degree, and I'm from South Florida. I live in the downtown area, and what I like about there is it's close to the Inner Harbor, so I like that it has the, the aquariums there, and sometimes there's a big place called Power Plant Live that every few weeks I go to with my roommate, and our rent is around $15.63 a month, and with utilities it's around $1,700.
And are you sharing that cost, or is that just you?
Yeah, so so we split it. It's we split the rent, and he pays for the cable, and I pay for the light bill.
Thanks, Johnny.
Hi, everyone. I think I've met all of you before. I'm Miriam, and I live in Upper Fells Point. I really love the area. Hamish and I live in a row home. We've got one housemate who is a Baltimore semi-long-term resident, and we rent the loft and essentially share the rest of the home with her. I really love the area because it's a 10-minute walk up to the School of Public Health. It's about 5 minutes across to the Patterson Park area, which is really beautiful, especially beautiful in autumn or fall. And it's about 10 minutes into the Inner Harbour and another 10 minutes down to the water. So it's been really a perfect spot for us to explore Baltimore from. I also really like it because it's real. You really do feel like you're living amongst real non-Hopkins people in Baltimore, and we've been able to meet lots of nice non-Hopkins related folks in our neighbourhood, so that's been really good. And there's a mix of pretty wealthy people and middle-class people and poor people, which for us was a real pull because we wanted to experience what Baltimore was really about.
I'm Josiah. I'm an MPH student. I live in Butchers Hill, and I'm coming from Philadelphia, so I'm a good person to ask questions to if you're interested in cycling, biking for commuting, walking. I don't have a car. And so for a lot of those reasons is why I really love Butchers Hill and think I sort of accidentally ended up in a great spot. I walk to school every day. It's 6 or 7 blocks. If I'm running late, I can bike. It's also just a 5 or 10 minute walk down to Fells Point where there's all kinds of bars, restaurants, whatever you need. There's a Safeway down at the sort of northwest edge of Canton, so we can walk there for groceries. Also, it's great to be able to run or walk along the water in Patterson Park, 2 different great options if you want to just get off the grid and sort of be out a little more connected to nature. So, yeah.
Hi, my name is Lucy. I'm in the MPH program, and I live in Mount Vernon, which is a good neighborhood. There are a lot of grad students there, so unlike Miriam and Josiah's neighborhoods, it's a little bit more Hopkins-oriented. But it's right on the shuttle route, which is nice.
Sometimes it takes us.
So it makes it really easy to get to school. It's probably about a 10-minute shuttle ride. I do also have a bike. I was living in Philadelphia before as well, and I bike to school. Sometimes I have to say I don't always feel totally safe biking because there aren't great bike lanes connecting Mount Vernon to this side of town. But once you get over here, I think it's very bikeable. Mount Vernon has one small grocery store that's very convenient. There's also one in downtown that's pretty close by. There are a couple of good bars. There are some restaurants. There's a great Ethiopian place. It's pretty. I have biked to Druid Hill, which I'm not sure is on this map, but is another kind of green area that's nearby and that is very bikeable from Mount Vernon, so that's nice. And I also have to say that I have a lot of friends that live in other neighborhoods in my program, in Fells, Upper Fells, Butchers Hill, Patterson Park area, and I spend a lot of time over in those areas and find it to be doable even without a car.
Hi, my name is Erica. I'm a second-year PhD student in International Health, Social and Behavioral Interventions. I live in Charles Village, which is right by the Hopkins Homewood campus. And again, the shuttle stops right there. There's a Homewood to the medical campus shuttle that goes quite frequently. So Charles Village, there's a lot of both undergrads, I think a lot of professors as well, and other graduate students from the medical campus. And then there's also families, there's green space, like as well as Droid Hill, there's also like those green spaces right around the Homewood campus, like a dog park and other things. Yeah, so if you have any questions, we have grocery stores, several of them, small and big. What else? I don't know. It's easier to park there, I think, than some city spots. So that's like a draw if you do have a car. I don't have a car, but I'm still fine getting around without a car.
Hi, everyone. I'm Jacqueline. I'm a second-year SEM student, Master's of Science student in the Department of Biochemistry and Molecular Biology. And so right now, I currently live in the downtown area, specifically in that area right underneath where it says downtown. And what I love about living downtown is that I don't have a car here in Baltimore. And so it's really nice just because if you are taking public transportation, basically all of the routes that you'll need to get anywhere around the city go right through the heart of downtown. Prior to moving downtown, though, I was living in Highlandtown, which sits at the eastern end of Patterson Park. And so that's a really great area as well. I was living in a row home there versus a high-rise apartment building where I'm living now. And what's great about that part of town is that if you're looking for more of a homey feel, it's nice in that what you'll find in Baltimore is that neighborhood pride and neighborhood personalities are very distinctive. And Highlandtown definitely has a personality all its own. And it's a really great place as well if you're looking for something with more of a homey feel, or if you have a family or looking to relocate and looking for more of a sense of community with people from the Baltimore area.
Great. Well, thank you all so much for quickly telling us a little bit about where you live or where you have lived. We haven't covered all of the neighborhoods because there are many more, but what we're going to do now is give you an opportunity to ask questions of us. And panelists, not every panelist needs to answer every question for the sake of time, so we can answer more questions, but we'll do our best. So raise your hands if you have questions. I saw your hand come up first.
Okay, so I'm going to say something more specific, so sorry to everyone that may not be applicable to. So I've lived in Federal Hill for like 2 years, 2.5 years. Do you all have people in the program or your programs that do that commute? I do have a car. Is it bikeable? Is parking just like a disaster trying to drive there?
So I have to actually repeat the questions because we're being recorded, right, Leslie? Doing my job. Okay, so Federal Hill, that's my part of town. So for Federal Hill, I drive because I have to drive so much in the community, but from Federal Hill, there's an easy walk about, 6 blocks maybe to the subway, and then the subway drops off right next door at the hospital. So it's very easy. Depending on where you live in Federal Hill, about parking, some places have parking. Parking can be a challenge over in Federal Hill. But coming here, oftentimes students end up parking in kind of our satellite lots because they're much cheaper to park at, which is oftentimes why people prefer to do the public transportation and do the subway.
Where's the subway stop?
The subway stop is right next door at the hospital.
No,
from here, it's downtown, so you would walk up Charles Street. It's kind of like around here.
Okay.
Charles Street. Yeah. Okay. Right over here.
Are there any ballet studios around the area or any kind of dance studios?
So the question is, are there any ballet or dance studios?
So I looked into this some because I used to dance, and Mount Vernon actually has Peabody, which is really great. They have adult dance classes, they have ballet, and some beginning like contemporary dance. There also is a dance group at Hopkins, I think it's called like Hopkins Dance, And they have classes a couple times a week in Charles Village that are free. I actually have never made it to any of them, in part because I don't live in Charles Village, but they seem great, and I'm on their listserv.
Okay, let me get this side over here.
Cars, like you, I mean, several of you mentioned you do not have cars. What's the general?
Okay, so the question is to car or not to car? General consensus. Oh, this mic.
I mean, I think a lot of that just depends on your lifestyle and whether you're interested in having a car. If you do have a car, there are definitely some neighborhoods where parking is more difficult than others. I think that the North Baltimore neighborhoods tend to be easier, not that it's impossible to live somewhere else with a car, but I think it's definitely very feasible to live without a car if you don't have one, if you don't want to have one. I think that's the general consensus.
Mm-hmm. I would also, it depends on how much Hopkins stuff you do and how much other life you do. Like all Hopkins stuff is all connected by shuttles, but if you want to have a life outside of that, then I think it's a little bit more difficult. I mean, they have the free circulators.
Charm City
circulators. But yeah, you got to live by one. I think they're limited.
I also drive a zip car from time to time because I found that compared to Philadelphia, it is a lot harder not having a car.
Okay. All right, in the red right here. Oh, great. All right, so we're going to pass it around to find out what are rents. How much are y'all
in Charles
paying?
Village, I live in a row house with 2 other people, and we each pay about $500. So really good price.
And I live in a row house that's been converted into apartments, so we have the entire 3rd floor. I live with 2 other women, and we each pay $600 plus utilities.
So when I was living in Highlandtown, I was in a 3-bedroom row home, and that was, I want to say, $1,400 for the entire place plus utilities. Now I live downtown in a high-rise, and for 1 bedroom, it is $1,300, all utilities included.
I live in the 1st floor of a pretty large row home in Butchers Hill, and I live with my partner, but you could easily have a roommate, and it's $729.
Hamish and I live in a pretty big row home, but we share it with one other woman, and we pay $850 a month plus utilities for the both of us.
Okay, great. Other questions? Way in the back. You.
Okay. I actually wanted to know, based on your previous experience that you guys know, is it very common to have people actually commute from Washington, D.C. all the way here?
So the question is it common to have people that are commuting from D.C. to Baltimore? Okay, Josiah.
I know it is common. It's pretty easy. There's a MARC train, which is $7 each way. It doesn't run on weekends. You have to take Amtrak, which is $16 each way. But MARC is really easy. Takes 45 minutes each way.
Yeah.
Yeah. Here's someone.
Yeah, you can do a monthly pass if you're going frequently.
You can also get a student advantage card, and then it's $525.
I mean, you can take them really early in the morning, and they go till about 10 or 11 at night, so, yeah.
And I know at least one girl in our class, I think, drives sometimes, so that's doable.
It helps if you live by the train station on either end.
Okay. Right here.
Can I ask your commute experience from the Homewood campus area each day?
Yeah, so I had walk maybe like 7 minutes, and then it depends on traffic. So if it's during rush hour, it can take like 30 or 45 minutes. So it can take a while, but like I just came right now, and it probably took like 20 minutes. Yeah, on that free shuttle.
And I wanted to ask a question about Butchers Hill. Scale of 1 to 5, what's the safety and the noise level in that area?
It's a very quiet neighborhood. It's close to Fells Point, but it's not a nightlife area itself. There's not, you sort of have to walk 4 or 5 blocks to get to that stuff. So I'd say it's very quiet. As far as safety goes, my wife, I don't think she's ever felt unsafe. I haven't felt unsafe there at any point. I think that just like anywhere, you be smart, probably, buddy up walking at night. Not me so much, but I'm also from Philadelphia, so I'm not sure. Like, I might have a higher tolerance.
I live just next to Butcher's Hill. I don't really know what the distinction is between Upper Fells and Butcher's Hill is, but I don't know. I think it's a city, and I've lived in other cities around the world. You've got to be reasonably safe, but I've never felt unsafe or threatened in that area.
Right. Okay.
You know how, so the buses run really frequently. Is there a time at night where like you don't really want to get like stranded, kind of like if you're here really late and the buses stop running, is there kind of like anything you can do at that point if you do live far away and don't have a car?
So let's talk about our buses when our buses stop running when you're studying late.
Well, I know like with the circulators, I think they stop running in the week times at like around midnight. So, but if you're in an area where there are a lot of circulators, there's probably going to be taxis. So you can always, take a taxi home.
Well, I guess it's also partly relative what you mean by living far. For instance, when I was living in Highland Town, I would take the bus throughout the evening. It comes every hour after around midnight, so it's not as if you're waiting forever for it. Plus, there are security guards at every corner of the campus in front of the bus stops, and usually I'll just spend the time talking to the security guards until I'm waiting for a bus to come. They're actually supposed to escort you and wait with you if you want them to, so it's not as if you have to wait it out alone if you're waiting for a bus late at night.
I'll say I've also started taking taxis for the first time in my life here in Baltimore because they're really cheap.
Okay, other questions from here?
I went to the house fair yesterday and heard about some new places that are popping up, a block or two off campus, remodeled places. I know the area around campus doesn't have the best reputation for safety. What are the thoughts on those new places that are popping up?
So the question was, what kind of thoughts do people have of like the new places that have been popping up around campus, like the 929 building is the big one nearby that people...
So I don't live in one of the new areas around campus, but I have a lot of friends who do, and they really like it. And a lot like that's really close to campus, and that it like relatively they're paying much less in rent than I am because utilities are included, and they've split up the rent. So the 929, from what I've heard, is a very nice place to live. Yeah.
I think it depends on what you want. We looked at living at 929 and decided that we'd just be spending all our time at Hopkins if we did that. But some people really like that. I mean, it's 5 minutes max walk from here, and it's really social, and there's lots of other Hopkins students around, so if you ever want a friend to spend an evening with, you just need to knock on someone's door. And Hamish and I didn't really need that when we came here, but lots of people like that.
Okay, let's take a couple more. Way in the back. So it's a good question, and the question was, what neighborhoods would you advise us to stay away from? And actually, I'm going to say I prefer not to answer that question for this reason. We're talking about the popular neighborhoods, but in every neighborhood in the city, one of us is from. Whether I'm from there, somebody that's on our staff is from there, our faculty and other students. So, safety-wise, things can happen in every single neighborhood, even the best neighborhoods. So what we're really trying to do is highlight to you what are the more popular ones from the student vantage point versus saying, oh, don't go live there, because people are going to find a different neighborhood really interesting for various reasons. So I think it's really hard to say, avoid that. Yeah. There. So the question is, what's the Hopkins shuttle schedule like? Okay. Erica uses it all the time.
Yes. So in the morning, they can go from like every 5 to 10 minutes, and same with the evening, the rush hours. And then in between, they can go from like 15 to 30 minutes. The only time it's really bad is on the weekends when they run only once an hour, and that's when it sucks.
Well, also too on the weekends, specifically Sunday, it doesn't start until noon. So if you're somebody who likes to get your work done in the morning, it's probably best to try and find some alternate mode of transportation on weekends.
Although Saturday it does start at 7.
Yes.
I know that one. What time does it start on weekdays? Anybody know?
Early, it's like around 5:30, 6 o'clock, and it ends around midnight.
Great. Right here.
A few of you mentioned having bicycles. I come from a very bike-friendly city and was thinking at first bringing my bike to commute around, but some of you mentioned that you sometimes felt unsafe. Would you not suggest bringing a bike as a
So our question is about biking.
So I come from San Francisco, and we are pretty bike friendly there. Baltimore's improving its bike friendliness for sure. There's certain routes where it's really hard to bike. For instance, if you're coming from the downtown Mount Vernon area, because basically you're taking a major thoroughway east-west is how you're getting to campus or going back home. And so it becomes a little bit more challenging. If you're coming from one of the neighborhoods directly around campus, it's a little bit easier. Also, another good thing, though, is that if you're trying to travel north-south, there's a bunch of bike trails that they do have running in that direction, which is nice. Also, too, if you plan on mixing bikes with public transportation, there are no rules regarding taking your bikes on the subway, on the light rail, so you feel more than free to do that if you need to. Yes.
I think Baltimore's really made a lot of improvements from what I can tell over the last couple of years. They're really trying hard. I think they're even better than Philly in a lot of ways. In terms of like deliberate strategic bike lanes, there's great north-south access. You can go along the water. I think it's a great bike town.
And you want to mention where you can leave your bike when you get it to school?
Oh, yeah. And there's a bunch of bike racks inside the parking garage that's underneath this building. And so we can park inside, lock up, security guards there, protected from the elements. It's great.
Okay. A couple other questions. Way in the back. So the question was about, is the campus populated up until a certain time?
I mean, I think a lot of people go home around 5 or 6 because that's the end of the workday. And I think because a lot of us are grad students, many people work at home or, in their neighborhood in the evenings and just get tired of being here all the time. But that being said, I've had classes until 8 or 9 and it's fine to be here. And I think there are some people who like to stay till all hours. Mm-hmm. And because of the security guards, I don't think it's really unsafe to be here.
I would say in general, I know some of you are worried about safety. I have never felt in any danger here in Baltimore. I know a lot of you have heard, oh my gosh, you're going to Baltimore, don't leave your house, And I would say that when I came here last summer, for the first 2 weeks, I listened to people. I was I felt like I was a hostage, And then I decided that I was not a hostage and I was gonna go out. And I think once I decided I was gonna lose that mentality, I actually started to enjoy myself. And so you're gonna hear lots of things and you're going to, some of you probably watched The Wire and all of that. But I have physically never felt in any danger, and I have friends who, I'm embarrassed, but I've walked back from, don't do this, but from Fells Point all the way to the downtown area at 1 in the morning, and it's a 40-minute walk. And I don't like that I've done it 2 times, but I have never felt in any danger. And someone from Source, his name's Noah, one thing he said is no matter where you are, if you approach low-income neighborhoods is with just people and you respect them, that you're really not going to have any problems. So I think that's one thing to keep in mind.
I think it's a really good point because people don't realize just how friendly of a city Baltimore is. You go out and you meet people in the community. Most of the time when you're going out to our community organizations, they're not going to extend a hand to shake your hand. They're going to hug you. Baltimore is a very friendly place. People are going to say hello. And I think all the panelists have echoed, we feel safe here. And I'm a female that lives here. I walk around Baltimore in the various neighborhoods, and it's just a wonderful city if you know your resources. And if you become street smart, Shouldn't be a problem. The other issues that you hear about, like when we talk about the wire and crime statistics, oftentimes the crime statistics are about the drug trade. So if you're coming to Baltimore and you're not purchasing or selling drugs, that's a good thing.
Well, also too, I'd add that we're adjacent to the hospital. There's always going to be people around. I'm in the lab, so my hours are super odd, and you're always going to find a bunch of lab rats trying to hop on the last shuttle of the night at midnight. So really, although it may seem like the room that you're in when you're studying here late becomes dead silent in the middle of the night, there's always going to be people on campus.
Over here.
On that map, where's the Target, the Whole Foods?
So Target is actually next to Mendelman Mall, which is on the west side, and doesn't show up on this map, but by the subway, it's about, from Charles Center where I catch it, it's about 5 stops down west. So that's where the Target is. The Whole Foods is right down in the Inner Harbor area, and so the green Charm City circulator line, as well as the orange line, go directly in front of it. So it's pretty easy to get there from downtown, and the green line also goes all the way up to the Hopkins campus.
And I think they're opening a Target. Is it in Canton that's going to be opening? Target's coming to Canton, which is another neighborhood down here, really popular. Okay, let's see. What area? I haven't got you right in the front.
I had a question, like a more academic question. So compared to other institutions you've attended or like looked at for graduate studies, how devoted have you found like the faculty here? How approachable are they for research and like academic related questions?
So the question was about how, compared to other academic schools that you've been to, how have the faculty been in terms of approachability and working with them?
I mean, I would say I think people are very approachable and eager to help you. I'm also in medical school at the University of Pennsylvania, and I don't see huge differences between the two, honestly. I think generally, if you are directed in your questions or in your desires to work with people, they will respond positively. I think that they are really busy and they can't respond as effectively if you come to them with really broad questions or if you're not responsible on your end. But if you're directed, they will receive that well.
I found faculty incredibly approachable here. And even though people are really busy, as Lucy said, they'll schedule you in like weeks in advance. And that's one of the really big things that I've been impressed by here.
So we have time for a couple more questions, so I still want to take them because there's lots of hands. What other Baltimore-based questions do you have? In the middle, right here.
Especially those coming from outside of the area, how did y'all find your apartment, row house, whatever, when you first came to Baltimore? How did you find
So the question is, how did you find your housing?
I use this cool app called PadMapper. I'm not sure if you guys have used that. It just overlays all the Craigslist listings on a Google map. One thing that freaked me out when I used it was I overlaid a map of the crime statistics. And then coming from Australia, where we don't really have shootings, I got really scared. And then I looked at the broader United States, and it was exactly the same everywhere else in the United States. But it was a really neat little tool to be able to kind of work out how far a walk it was to different places, where the nearest grocery stores were, and how different houses look like.
I found mine on Craigslist, and it's through a real estate management company, and just saw it once, went to the office, signed up.
So I was fortunate to do research here last summer. So I was already here, and the research place gave me housing. So what they did was, towards the end of my research, I decided to just go on the road, and I walked around, and any place that looked like an apartment that was leasing, I just went in and got information. And I did that for around 2 weeks before I found my place.
And I found my actual apartment through Craigslist, but I found my roommates through the Hopkins Roommate Finder website, which I think is in your packets, and they're great, so I would recommend that.
Also, I just want to throw out there that every year there's a JHSPH Facebook group, and that's also another great way to find people as well.
A lot of people have also taken advantage of Visitors Day and met people here. make a friend, to decide. Let's live together. Way in the back. How much time does it take you to find a place? Are they in high demand?
I think it's fairly quick. Like I put mine up for sublease in the summer. Like there's a lot of subleases too. Like and someone, because it's good price, like, you know, I got like 20 responses in the first 2 days and found somebody already. Like, and I found like that's the same with everybody. Like it's pretty easy to go in and out. I think to find it, how long does it take to find it?
Maybe he's
Oh, okay. I guess it depends on how formal it is.
I think you have a little bit of leeway. Like you can find it in advance. I know a lot of people came here with sort of temporary accommodation and then found something once they came here. I don't think you have to stress terribly much.
Yeah, it's not DC or New York. So, I mean, I was out of the country. I came here, and within a week, I found a place. I'm not saying I recommend you do that, but it worked.
Oh, yeah. Okay. So I have time for one last question, which means it should be a good question. We'll all be judging you. Just kidding. Right here.
Well, actually, kind of two questions. One was, I wanted people to sort of speak to neighborhoods in terms of, especially for me, because I'm a light sleeper, but in terms of noise. Like, for instance, if you're living next to campus, like if it's next to the hospital, is there always, traffic in and out, ambulances and things, or like what places are noisier and quieter? And then the second one was, piggybacking off the car question, if people could kind of speak to it in terms of like whether to bring a car or not in terms of cost effectiveness. Like for instance, parking expensive within where communities that you live do does housing offer parking, and if so, like how much is it costing?
Okay, so trying to sneak in a two-parter. I like that. Good thinker. Noise in your areas, and also the car costs about parking, because you have to park at your place, and then you have to park at school potentially. So noise and cars.
So I live right by the light rail, and the good thing is I'm on the 9th floor, so it's not so bad, and I got used to it, but I don't think I would recommend you do that. And my roommate has a car, but he's from Virginia, and he decided not to bring it because the parking was too expensive. So again, it depends on the person. So, I'm very, I don't really do much, I'm like very boring. So I didn't really need a car, I just used the free buses.
Johnny actually does a lot in the community, so.
We use a Zipcar a lot. It's been great. There are heaps of Zipcars around here, and we weren't going to bring or buy a car while we were here. And it wasn't, I think we've saved a lot of money by not having a car.
Cars and noise.
So Mount Vernon, I would say, is noisier probably than the neighborhoods closer to school, just because it's, well, okay. I mean more like their neighborhoods, I guess, just because it is more of a city feel, and I occasionally get woken up at night by people shouting on the street, or something like that, but it doesn't bother me. I don't have a car. I use Zipcar. If you do have a car in Mount Vernon, if you want to park on the street, it's free, but you have to change your registration, which I've been told takes 2 different trips to 2 different offices, so that might be annoying. And if you want a parking spot, I think it depends, but it can be like $100 a month, maybe $200. So it's not cheap, but I don't know what that compares to in other places.
Yeah, my roommate, like we have a parking space in the back of our row house, so that's free. And then my roommate pays, it's like $10 for a year for street parking, so that's nothing.
Yeah, depending on the neighborhoods, some of them are permit parking, and it's an annual permit renewal, and some are free, some are $10. Mine was $20 a year and $20 a year for a guest pass. But then if you're living in a high rise and they have a garage there, you're going to pay much more to have your car parked in a high rise. Yeah. Parking at the school. So most of the time, I would say you park in the satellite lots because that's where the students park. Shayna, I'm looking at you. How much is parking for the satellite lot?
We have one
$55 a month for parking. It's walkable and there's also a shuttle. See, I'm repeating because Leslie told me we're recording. I follow my instructions.
You do.
Well, with that, let me just say this. We will be kind of hanging out when you guys are momentarily going to be picking up your box lunches. We'll hang and ask if you have other questions, but you're going to be meeting other students, other folks to ask questions of. But join me in thanking our panelists to take time the other day.
Okay, sit tight for just a minute or two. I'm going to try to go really fast. So what we're getting ready to do is we're going to break out into our departmental lunch sessions, if I can say it. This is when you have the opportunity, like I said, to meet with your specific departments and programs. If you are admitted to multiple departments or multiple programs, this is up to you, where you want to go and how you want to split it up. What we're doing is we're going to go back to Finestone Hall where breakfast was served. You're going to pick up a beverage and your box lunch and then take it with you to your room location. The room locations are all listed on your agenda. They're pretty self-explanatory. The first digit is the floor level. So if you're on 7039, go to the 7th floor. And then we do have signs throughout the building to help you find the location. And there's also maps that are on at every elevator. Those who are in the Department of Mental Health, we are going to have an escort take you down to Hampton House. So just meet where you picked up your packet this morning, just out in the gallery. We'll have Amy Galloway will be taking you down there. Please note that these department sessions will end at various times. So we are starting the information fair and also campus tours, kind of just trying to please whoever can come at different times. You're all going to be, some departments will meet for an hour, others may meet for a few hours. So just know that you're all coming out at different times. But take advantage of that info fair and the campus tours, which will all be happening out here in the gallery. What else do I have to say to you? We are going to be taking campus tours. If you've come before and you've done the little tour that's on a Friday afternoon at 3 o'clock, it's basically the same thing. You're more than welcome to do it again. But we did include personal walking tours in your packets, which are a little bit more extensive and take you over to the hospital and down to Hampton House as well. So that's up to you what you want to do as far as that goes. As you have known throughout this day, we have been recording this session. So if there's anything you missed or you wanted to hear Andrea Galen's presentation that was in this room for the seminar series, we're going to be posting those on the Admitted Student website next week. And we also have some upcoming master's student panels, online sessions that will be occurring next Wednesday. So there's a lot of opportunities for you to stay connected with us after you leave. Okay, I'm done. Does anybody have any quick questions? I know you're hungry. You did well. So enjoy your afternoon. Thank you so much.